All right, so I got the chat box up if anybody has questions as we go. Otherwise, kind of like I was saying, it's really going to be just back to the basics, right? Just pure foundational cardiac anatomy and physiology. And then we're going to kind of work our way from there for a little while. So we're not going to go, insanely in depth into electrolyte channels and all sorts of stuff. We're just going to start with the basics of it. So with all this, it's going to be a lot of drawing, a lot of talking, and just a small handful of pictures that I have, not actually anything even in the way really of the words for it, right? So cardiovascular system is where we're going to spend the time this morning. All right. And so some of the stuff that we're going to talk about, we're going to start with, we're really going to go outside in. Right, so we're going to say, what is that space that the heart is actually held to, right? Or where is it actually located at inside the body? And then we're going to kind of strip out those areas and talk about the surface of the heart. And then we're going to kind of strip through the surface of the heart into the chambers and the valves and everything else. Right, so we're going to start our way from the outside in and touch on the electrical conduction system a little bit. I'm going to spend a little bit of time, just a minute or two, talking about some of the terminology regarding blood vessel walls, right? We don't talk terribly long about it beyond just those couple names. Right? All right, and then a little bit on blood, right? So whole cardiovascular system, most of it on the cardiac side, right? Most on the heart. All right. Cool. So we have the heart, we have all the blood vessels, we have the lungs, right? We always really talk about it in the terms of, the cardiac and the respiratory system, right? They go hand in hand together. So you can't have one without the other, right? Fancy in the book, they'll talk about the ventilation perfusion ratio, right? Which is ventilation referencing oxygen coming in and out, and perfusion referencing actually circling it, right? We're going to talk about that just as a concept, right? If we're breathing or if we're bagging our patient and we're getting oxygen into them, but the heart's not beating to actually circulate it, then we're dead, right? Same thing, if the heart is pumping, but no air is coming into the body, it's useless, right? So we have to have both actually functioning together. Right? We have to have the appropriate amount of oxygen coming in and out, right? And we talk about that with minute volume, right? How much air are we breathing in and out over the course of the minute? And then we talk about on the cardiovascular side, where's my pen? On the cardiovascular side, we talk about with cardiac output, right? So minute volume is how much air are we breathing in and out over the course of the minute, and cardiac output is how much blood are we circulating over the course of the minute. Right, and both of those numbers need to be appropriate numbers, right, for the body, for what the body's used to, right? So they go together is really what I'm saying, and we talk about it with, CPR, right, cardiopulmonary resuscitation, right? It's just they're so universally intertwined together, right, as they have to both be functioning properly. So within this entire thoracic cavity, I like this picture because it kind of looks cool and it's bright and colorful, right? But it also really shows where a lot of this stuff is actually at and where we actually talk about a lot of it. Right? So the space in the heart, or the space in the chest rather, where the heart is located is your mediastinum. Mediastinum. Media is middle, stinum, think sternum, right? So we've got the sternum right in the middle, and there's that little space, that little compartment, that little area in between two lungs. We call that the mediastinum. And so if we could kind of separate this picture and draw some lines there where both of the lungs are, separate those out of the equation, it's just that stuff right in the middle. So we have the heart, we have the blood vessels, right, the big ones, the aorta, the vena cava, the esophagus running back there behind it is also a big part of it. Right, so all those structures are located within the mediastinum. That's why in trauma, sometimes you'll hear, you might hear a diagnosis of something called pneumothorax, mediastinum. Pneumo is air, mediastinum is referencing that space. So some air got pushed into that middle space, right? Kind of like a pneumothorax where there's air in the pleural cavity, right? Air in the thoracic cavity where the lungs are. We can get air in the mediastinum. Right? So that would be pneumomediastinum. All right. Cool. All right, so stripping out all of that so we can get a little bit more focused is we start looking at the heart itself. Right? And the heart, they say, is about the size of your closed fist. And so if y'all made a fist and figure that out, that's about the size of your heart, right? Put it right kind of dead center there. And so this picture really, again, is good just because it can help kind of strip away some of that distractions from that last one. Right, so I said we're going to start with the outside and work our way in. So let's start with even outside the heart just a little bit, is we have a little fluid-filled sac wrapped around it. All right, so we have that fluid-filled sac wrapped around it. We call it the pericardial sac, right? Or the pericardium, and pericardial. So cardio, obviously referencing the heart. Peri is around, so pericardial is around the heart, right? Around the heart. Cool. So this is where, you know, later on, we might circle back to this, just depending on time and everything this morning, on things like cardiac tamponade, where this sac is just getting fuller and fuller and fuller of blood or fluid or whatever it is, and all that pressure starts squeezing on the heart and starts causing problems. Right, so we have that pericardial sac, and then you can see, you know, all these blood vessels, right, that are going along the heart, right? That's because the heart, just like any other tissue, right, the heart needs its own blood supply, right? So those are coronary arteries and coronary veins, right? That's where we talk about somebody having a blockage in a coronary artery if they're having a heart attack, an MI, right? It's a blockage building up in one of these blood vessels on the heart, right? Actually on the surface of the heart, and they're perfusing the heart muscle, right? Just like your bicep, just like your fingers, just like everything else in the body, right? Your heart needs oxygen delivered to it so that the cells of the heart can stay alive, stay functioning, and everything fine, right? So if we didn't have the heart being perfused, just like any other tissue, it would die. And so if we had this blood vessel here, and we said this is where the plaque buildup in that coronary artery happened, and now all of this tissue underneath that blood vessel was responsible for perfusing, right? Now that tissue is going to start to die because of that blockage, that plaque buildup inside that coronary artery. Okay. So the heart needs its own blood supply, right? It needs that continuous flow of oxygen. Even though the blood is moving through the heart, right? The heart is pumping and circulating all of that blood, right? That blood moving through the inside of the heart, right? It's not absorbing oxygen through the walls of the heart like that, right? The way that cells get oxygen is because of the capillaries, right? Those teeny, tiny, tiny, tiny little blood vessels that come directly into contact with the cells, and that's where the oxygen and the carbon dioxide move back and forth, right? So we need those same kind of capillaries, we need those blood vessels there to actually be able to get a good amount of oxygen and everything to that cardiac tissue. All right. One layer deeper. One layer deeper. We're going to stay here for a little while. All right. So going through, if we were just labeling it, right, we have this blood vessel bring blood in. There's another one that's not really shown back here, and it's bringing blood also up in here. Right? So we have the superior vena cava, right? Superior vena cava, right? Vena is vein, right? Superior is from the top, right? So superior vena cava, and we have the inferior vena cava. All right, so they're all bringing the blood back from the upper body. Superior vena cava is bringing blood back from the head, shoulders, upper body, back to the heart. Inferior vena cava is bringing everything up from the bottom of the heart, or bottom, lower half of the body. So everything from the abdomen, the legs, all of that is coming back up the inferior vena cava, inferior vena cava. And so all of that blood that's coming back is deoxygenated blood, right? Because it just delivered all that oxygen out to the tissues, out to the body, out to your fingers, your toes, everything else, right? So it delivered all the oxygen and it picked up all of the carbon dioxide, right? So it's high carbon dioxide, low oxygen blood that's coming back to the heart, right? Because when we talk about cells staying alive, right? Cells staying alive, that is cellular metabolism, right? That's the actual cell, each individual cell doing the things that it needs for that single cell to stay alive, stay functioning, and keep working properly. So for cellular metabolism to work, amongst other things, the body needs, each individual cell needs that oxygen supply, right? That's why oxygen is so crucial for us. It needs sugar, right? It needs water, it needs the correct temperature, it needs lots of stuff, but really we're going to talk about the oxygen. So it needs oxygen to keep the cell alive. So the cell keeps making energy so that it can keep doing the things that that cell is responsible for doing. So it uses the oxygen, right? It uses the oxygen and it makes carbon dioxide as the waste product, right? So that's why we use up oxygen, we make carbon dioxide, right? So this blood, again, coming back from the body, it delivered all of that oxygen and it picked up all that carbon dioxide waste product, right? And it's bringing it back to the heart so that we can get it to the lungs so we can breathe out that carbon dioxide. So oxygen is used, carbon dioxide is wasted, right? So we could say it's, again, it's deoxygenated blood. It's referencing the low oxygen levels. And we could say it's hypercarbic blood, right? High carbon dioxide levels, hyper is high, carbic, or capnic, right? Hypercarbic or hypercapnic. We'll talk about carbon dioxide levels. All right. So that blood enters into the right atrium, right? Enters into the right atrium via, again, the upper body and the lower body, vena cava, superior and inferior vena cava dump directly into the right atrium. And right atrium's whole responsibility, if we're talking about functions or anything like that, the functions of the right atrium are purely just to receive that blood from the body. Right? So if your mind works on kind of like flashcards and you were doing functions of different structures, the function of the right atrium is to receive blood from the body, receive that deoxygenated blood from the body, and send it down into the right ventricle. Right? So we've got our right ventricle. And so one of the big things that we'll do is we're just going to label the structures on this one. On the next one, we're really going to, talk through kind of that flow and some of the ways to help remember it. But moving from the right atrium to the right ventricle is we have this little white flap there, right, or valve. And that one is your tricuspid valve. Tricuspid means there's 1, 2, 3. Right? There's 3 little flaps on that valve, the tricuspid valve. Generically, the tricuspid valve is between the atria and the ventricles, and so they call it an atrioventricular valve, or an AV valve. AV valve. right? So that tricuspid valve is an AV valve, right? It's located between the atria and the ventricles. Right? So that's kind of valve number one, right? If we were talking about blood flow working its way through the heart, the tricuspid valve is going to be that first one. Right? So that one's number one. And then the right ventricle, right ventricle contracts, right? And it sends blood up through another valve. Right? And that valve is your pulmonary valve or pulmonic valve. Pulmonic valve. And guess where that one's going? It's going out to our lungs. Cool. So pulmonic valve, again, just because like it's medicine and they want to make things more complicated by giving it more names. A pulmonic valve generically is a semilunar valve. Right? So I have the category of valves. So the tricuspid valve was an atrioventricular valve. The pulmonic valve is a semilunar valve. Right? That one's nice at least, right? Tricuspid tells us something about the structure. Pulmonic tells us something about where that blood is headed, right? So tricuspid, it had those three flaps. Pulmonic is saying that that blood is going to the pulmonary system, right? It's going out to the lungs, right? So once that blood goes through the pulmonic valve, right, it splits to go to the right lung and go to the left lung, right? And this blood vessel that's going away from the heart, right? Remember, arteries are away from the heart. So those are our pulmonary arteries, right? And it's one of those few times that, you know, we generally will think about arteries as oxygenated blood, right? But pulmonary arteries, right? Pulmonary arteries, right, is deoxygenated blood, right? So again, arteries usually oxygenated blood. Pulmonary arteries are one of those locations where it's actually backwards. And the pulmonary arteries, because all they're doing is pumping that blood to the lungs, and it's that blood that came back from the rest of the body, means it's going to the lungs so that it can get the oxygen, right? So pulmonary arteries are deoxygenated blood flow going through them. Right. So those pulmonary arteries branch down smaller and smaller and smaller to the pulmonary capillaries. Okay. And those pulmonary capillaries are what run directly up against the alveoli in our lung. And that's where we get the gas exchange to happen. Right? Right? That's the kind of key location of it, is that capillary, that alveolar capillary membrane. Right? That's where the oxygen that we breathe into the body goes from the alveoli, okay, from the alveoli into the bloodstream, the oxygen, and the carbon dioxide, as we said, the other side of this blood flow that we had was high oxygen with the low, or high carbon dioxide with the low oxygen, right? So the oxygen goes in, the carbon dioxide goes out of the blood vessels into the alveoli, into the lungs, so that we breathe it out, right? So that's where we get the flip-flop of the gases, right? We get all that good oxygen into our bloodstream, and we get all that carbon dioxide waste product out of our bloodstream back into our lungs so that we can breathe it out and eliminate it from the body. So that's at the capillary level. On the other side of capillaries are veins, right? So these are the pulmonary veins, right? And veins bring blood back to the heart, right? They bring blood back to the heart. All right. So this blood comes back, the pulmonary veins. There's actually two of them back there, right? This happened on both sides, right? So those pulmonary veins are now bringing high oxygenated blood and low carbon dioxide because it got rid of that waste product, right? So it's bringing that blood that's all full of that healthy, good oxygen that we're going to want to distribute throughout the body, right? And it brings it back up to our left atrium. So we have the right atrium on the right side, left atrium on the left side. Right, atria are on top and the ventricles are on bottom. Okay, so the function of the left atrium, right, we said the function of the right atrium was to receive that blood from the body and send it to the right ventricle. The right ventricle's function was pumping with enough force to get that blood to the lungs. And then the left atrium's function is to receive that blood back from the lungs and send it down to our left ventricle. Right. And we have our left ventricle. And then that left ventricle is going to pump that blood out, one extra valve right here, out the aorta throughout the rest of the body. Right. So again, left atrium receives the blood, sends it down to the left ventricle through another valve. And that valve is the bicuspid valve. Just like we had tricuspid valve on the right side, we have bicuspid valve on the left side because it has 1, 2 flaps. So bicuspid is 2. The other name of the bicuspid valve is your mitral valve. And again, because this valve is located between the atria and the ventricles, we can say that it is an AV valve as well. Okay. So just like our tricuspid valve over there is an atrioventricular valve, this bicuspid or mitral valve is also an AV valve because that's where it's located, right? It's between the atria and the ventricles. So be comfortable with using them interchangeably, whether you use bicuspid or mitral, just because you never know. Both are valid, so you could get a test question that's phrased with bicuspid, you could get a different test question that's phrased with mitral, and you need to remember that those are the same. Right, so bicuspid or mitral. The bicuspid references the 2 flaps. Mitral is a little bit more the shape. Right? If you think about the saw of a miter saw, or the teeth of a miter saw, that's where the name came from. A miter saw. That mitral is the shape of it, right? Or that old, really tall Pope hat, right? The hat that the Pope used to wear that was really tall and pointy at the top, that was called a miter as well. Right? And so again, it's just referencing that shape a little bit. And then the left ventricle, we said, contracts, sends blood out, 1 extra valve right there, 1 extra valve. And that is the aortic valve. So we've got 4 valves that the blood flow passes through. Right, the tricuspid was first. This pulmonic valve up there was second. This bicuspid or tricuspid valve is third. And this aortic valve in there is fourth. And the aortic valve, just like the pulmonic valve, is one of those semilunar valves. Semilunar. So we have 2 semilunar valves and we have 2 atrioventricular valves. 2 and 2. And so that left ventricle, right, left ventricle contracts, sends that blood out the aortic valve, out our aorta, which is the highest pressure artery in the entire body. Right? It receives the full force of that left ventricular contraction. And it's got to be enough pressure to pump blood up to the top of your head, out to your fingers and toes, and everything. Right? It's got to be able to deliver that blood with enough force. Right? That right ventricle, we said it only has to pump blood with enough force to get the blood to the lungs and back. Right? So it's not going to take much force. That left ventricle has to get it all the way out to your fingers and toes and everything. Right? So that left ventricle is a lot stronger. Right? Some diagrams do it. This one is a little bit. But since the heart is a muscle, the harder you work a muscle, the stronger it's going to get, the bigger that muscle is going to get. And so some pictures are really good about it, but the wall here of the right ventricle is smaller than the wall of the left ventricle, right? because that right ventricle doesn't have to work super hard to get the blood to the lungs and back. Right, very small distance that it has to be able to send that blood. So it doesn't have to pump very hard, doesn't have to actually, require that much force, so that muscle doesn't get bigger and bigger and bigger. Right? That left ventricle, though, we said that's the one, it's got to pump to get blood everywhere throughout the entire body. So that side of the heart has to work a lot harder. Right? So that muscle is usually bigger when we actually look at it. Right? And then we said the aorta, that's going to branch and take that blood everywhere throughout the body until eventually it circles around and comes back to the right atrium, and the process repeats itself. So I was looking at this, I'll give you a clear picture, and I was trying to figure out, because mapping the path flow of the blood is just a critically important tool to be able to do, is to actually move that through, is to be able to say, okay, oxygen or blood moves this way through the heart, because when we start talking about stuff like CHF, congestive heart failure, and the heart's not working well, then we can kind of work our way backwards, right? And say if the left ventricle isn't pumping blood forward, then it's going backwards. Right? It's either or, it's not just sitting there. Right? If it's not going forward, it starts to back up. Right? So that left ventricle, if it's not pumping it out to the aorta, that would mean blood would go from the left ventricle back up to the left atrium, and then out the pulmonary veins back to the lungs. Right? So if we have the left ventricle failure, or left ventricular failure, or left-sided CHF, right? The left side's not pumping it well out the aorta, means it starts backing up. And so if we know the path flow of the blood, we can follow it back to the lungs. Same thing if there's an issue with the right side and that right ventricle wasn't pumping stuff well to the lungs, it would back up from the right ventricle to the right atrium. And then the right atrium would go out the vena cava back to the body, right? And we talk about kind of gravity dependent edema. So it's super important to be able to follow that blood flow normally so that later we can work backwards with it. Right? So that later we can work backwards. And so one of the things that, you hear a lot of students asking about, or questions that get asked about, is, the order of the valves. Right? And we said, starting with where the blood flow is going to pass through, it's going to pass through the tricuspid valve, and then the pulmonary valve, and then the mitral or bicuspid valve, and then the aortic valve. Right? Tricuspid, pulmonic, bicuspid or mitral, and then the aortic valve. And so I was looking at this, and my brain always just worked kind of well to just memorize medical textbooks and anatomy and physiology. But every time I teach it, I'm trying to constantly look for just different ways to make distinctions so that something will click with a student beyond just saying, memorize it or study harder. And those are kind of useless statements for a teacher to make, right? So TPMA, right? And I've definitely heard people say, toilet paper, right, we can just follow it there, right? Toilet paper, my ass, to put them in order, TPMA. And that works, right? That works, toilet paper, my ass, right? Puts them in order. I was also looking at it just last night, and I never actually just realized that it's reverse alphabetical order. Right? And reverse alphabetical order still works whether you call it the mitral or the bicuspid valve. Right? So the order that they go through is backwards in the alphabet. So if you just remember the four of them, and then you put them in alphabetical order, you can work your way backwards through it. Right? Tricuspid is first, then pulmonic, then mitral or bicuspid, and then arterial. See a few questions coming in. All right. All right, so the blood that perfuses the lungs, does it come back to the heart before perfusing the lung? Or is there a vein before the heart that perfuses the lungs, bypassing the heart, lungs, and veins names? I'm trying to understand that. Veins that are actually feeding the lungs.
Yeah, when it comes to pulmonary perfusion, do the pulmonary veins start about where the coronary veins start? Just outside the vena cava, or is it somewhere else? I'm sorry, just outside the aorta, or is it somewhere else?
Let's circle back to that one in a little bit. Let's circle back. That's a good question. So just like the heart is tissue, and it needs that blood supply, keeping that tissue alive, but the lung is tissue as well. So like we said, all this blood moving, all this blood moving through the heart isn't like the heart's not absorbing that oxygen into the walls of it, right? So that's where we actually have to talk about, we will circle back to those coronary arteries that feed the heart, and we can circle back to those blood vessels that feed the lungs as well. So that's a good question. All right. So valves is where we're at. Right? So TPMA, reverse alphabetical order. Right? Reverse alphabetical order. Or toilet paper my ass, if that's helpful for you. If that's one way to actually remember it. The other stuff that we talk about is high pressure versus low pressure, right? Or pulmonic versus systemic circulation. Right, so if we were looking at it and we said the right side only has to pump with enough blood flow to get the oxygen to the lung, or to get the blood to the lungs and back, and that left side has to pump with enough force to get the blood out to the fingers and toes and everything, right? That means the right side, right? The right side and the left side, remember we're orienting this for the patient's right and the patient's left. So the right side of the heart is the low pressure system, and the left side is the high pressure system. Right? It's low pressure, it's receiving that low pressure blood through the vena cava back to the heart, and it's pumping it comparatively weakly out to the lungs, right? Just right there. So that left side is lower pressure, doesn't have to work as hard. Right? Unless something is going wrong, then it might have to work harder. But generally speaking, when everything's going fine, that right side is a low pressure side, doesn't have to work very hard. That left side is receiving the blood from the lungs, and we said it's working hard to be able to pump with enough force to get that blood out throughout the entire body. Right, so that right side is the low pressure, and the left side is the higher pressure. Now, adding in a few more structures to it, is we have these little white bands that are anchoring the flaps of the bicuspid valve here. They're on the left side, or on the right side as well. They just didn't put them on the diagram, right? But they're over there. They're anchoring those flaps of the AV valves, right? Because those ventricles are strong enough that they could push blood back up into the atria if we didn't have those valves, or if those valves just opened up and went with them. Right, so we have these little kind of strings, these little wires that are just kind of anchoring the valves. So when that ventricle contracts and we want all of that blood to go out the aorta, right, that valve needs to snap shut and it needs to stay closed. Right, if it doesn't close all the way, or if it opens back up, then that blood would go from the left ventricle backwards up into the left atria. Right? So we have those little strings, those little wires kind of anchoring it, helping hold it in place. And those are our chordae tendineae. Should be right, chordae tendineae. And again, they're just anchoring those valves, so when they snap shut, they stay shut. They don't open up, right? They don't stay partially open, they snap shut, right? And then those chordae tendineae are anchored to little muscle structures kind of on the floor on the bottom there of the ventricles. And those are our papillary muscles. So papillary muscles on the bottom, and they anchor, they kind of hold those wires there that are anchoring to keep those valves closed when the ventricles contract and snap shut. Right? Now, if you put your stethoscope on your heart and you're listening to it, and bump, 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 what we're hearing are those valves snapping shut. Right? We're hearing those valves snapping shut. That's the actual sound of those heart tones or heart sounds, or the bump, bump, right? When you actually listen to it, is valves snapping shut. Right? All making sure that when the different structures are contracting, driving that blood flow, that the ones that are snapping shut are the ones to keep the blood from going backwards, and the other ones are open, so the blood goes out the open one. Right? That's going to take the path of least resistance. So the one in the right direction opens up, and the one in the backwards direction closes shut. So it keeps blood moving in the proper direction. Good, good. Now the other kind of aspect that we have is actually the layers of the heart wall, right? The layers of the heart wall, right? So the body is designed a lot of times in 3 layers, right? There's 3 layers to the heart wall. A blood vessel has 3 layers. The uterus, 3 layers. The meninges wrapping around the brain, 3 layers, right? This 3-layer system is just a very, very, very common thing, right? The eyeball, 3 layers, right? So 3 layers over and over again. And so we're going to work our way from the inside out. Let's go the inside out. So lining, right? The little membrane layer lining the inside of the wall of the heart is the endocardium. Endo is inside, cardium reference in the heart. And then we have the big wall of the heart, right? That big centerpiece. And that's myocardium. Now, myo is muscle, or myo is middle in this case, right? But myo is muscle. So the middle layer is the myocardium, and then we have a little kind of thin outside membrane layer as well. And that one is the epicardium. Now, epicardium, epi is on top of or outside of the heart, so it's the outer layer. Now, interestingly, if we go back a couple slides, the epicardium, the epicardium is actually the inner layer of the pericardial sac, right? So it's the inside layer of the pericardial sac. It's the outside layer of the heart. So, I mean, it's all together, right? It's all right there together. So that epicardium is the outer layer of the heart, or the inner layer of the pericardial sac that continues around the heart. So the middle layer, right, is where we're getting a lot of the work done, right? Is that middle layer is almost always the key, right? Middle layer. And so the middle layer is generally, it's going to be that big muscle mass layer, right? It's the layer that's actually doing the work. It's generally the layer where more of the blood vessels are, that's actually kind of perfusing that tissue. It's always that middle layer. Right? So that middle layer is the big muscular layer. The other layers are kind of like membrane protective layers. That middle layer is what's doing the work. Right? That's why we talk about somebody having a heart attack, an MI, a myocardial infarction, right? It's telling us that that infarction is on that middle myocardium layer, right? That's where that blood flow is actually getting blocked. Can you have issues in the endocardium? Yeah. Can you have issues in the epicardium? Yeah. But that big issue that we talk about, that heart attack, right? Assume the worst, hope for the best, right? Assuming the worst is that that heart tissue is actually dying, right? That myocardial infarction, right? So it's always that middle layer. When we talk about the blood vessels in a little bit, the blood vessels, right? The walls of the blood vessels, there's 3 layers. That middle layer is the big muscle mass layer. Right? On the 3 layers of the uterus, that middle layer is the big muscle mass layer. Okay? if we were talking about the meninges, right, those meningeal layers, that middle layer, the arachnoid layer, is the highly vascular layer, right? That's not a muscle-driven thing, but that's where all the blood vessels are, or a lot of them, right? Is the middle layer. Right, so that middle layer is where we usually will spend more of our time talking about, because it's the one kind of doing the things that we're talking about. We're talking about that heart contracting, the muscle contracting, that's the myocardium in the middle. Now you can have an MI that has spread all the way across the heart, right, or the wall of the heart, right? So we said an MI initially might just be infarcting something just in the myocardial muscle layer, right? But if that death of that tissue is actually spreading across the entire wall, hitting the endocardium and the epicardium and the myocardium, right, they would use a term, transmural MI. Right? Trans is across, mural is wall. Right, so a transmural MI is an MI that has spread through the entire layers of that wall of the heart there. Right, not too common that you see that kind of term used or come up at all. Most of the time we just leave it at myocardial infarction, because that's where the source of the problem is. All right, so I think there's some questions. Let's see. All right, so Anthony says, try before you buy for orders of the valves. Tricuspid before bicuspid. Try something before you buy it. That's a good one. Then Andrea's jumping in the chat box, answering our pulmonary vasculature questions. All right, so bronchial arteries. All right, we'll circle back to those. So yeah, the lung tissue itself has its own blood supply. It's just like we have coronary arteries that go to the heart, or these bronchial arteries that go to the lungs and actually perfuse that tissue and keep it alive. I think that was the question that was up. All right. Cool. All right. So kind of circling back, and we've been talking about all the blood flow there, right? But we said it's the heart and the lungs, right? So we got to get it through. So it's a better visual than mine, right? But we have the pulmonary system, the respiratory system, right? Where we breathe air in the trachea, and it branches down our bronchi, down to the smaller bronchioles, down to the really small bronchioles, all the way down to the alveolar level. Right? So we have the tiny little bronchioles, right? And then we have the alveoli, which are kind of like the little grape sacs, right? And then we have the blood vessels, right? So we have, those are our pulmonary veins and our pulmonary arteries, right? So those kind of smaller branches off. As soon as the blood from the right ventricle, right, contracts, sends that blood, right, out the pulmonary arteries, they branch down smaller and smaller and smaller and smaller and smaller until we get to the blood vessels that really just kind of mesh right around the alveoli. Right? And we said those are our pulmonary capillaries, right? These little kind of blood vessels that are directly on it are pulmonary capillaries. And that's where, again, that oxygen moves into the bloodstream, right? It diffuses from the alveoli into the bloodstream, and that carbon dioxide that's in the bloodstream diffuses out back into the alveoli, and then it works its way back up the bronchioles, right? Back up our bronchioles, which eventually branch up our big bronchi, up our trachea, and we're able to breathe it out, right? But it's only once those big pulmonary arteries branch all the way down to this pulmonary capillary level that everything happens right here, right? The whole gas exchange purpose of us breathing, get the good stuff in, the oxygen into the body, and get the bad stuff, the carbon dioxide, out of the body. All of that happens here down at this level, right? Down at this level. Big enough to be seen, or are they microscopic? Really, micros, tiny, 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 tiny. Right? You can think about like an actual, you know, molecule of oxygen, right, is what's dissolving across it. So very, very, very tiny. Right?
Okay. The picture just looks like you'd be able to see it. The picture just looks like you'd be able to see it. So I was just wondering.
Cool. So, like I said, this is where it happens. It works its way back the pulmonary veins until eventually, like we were saying, the pulmonary veins eventually branched up larger and larger. Right? So out the pulmonary arteries, down to the alveoli, like this. And then gas exchange happens there at the alveolar capillary membrane. And then back up the pulmonary veins, right? Back into the left atrium, into the left ventricle, and then out. Right? So going back through it again, just, you know, ways that I typically have done it in classes is we'll have like an index card, and every index card has a different structure of the heart. So one index card might say tricuspid valve. One index card might say pulmonary capillary. Another index card might say left ventricle, right? And usually I'll split the class into two teams, and everybody has a full set of index cards, and it's whichever team can put them in order the fastest. Right? So that might be good. That's something that you can do even just on your own, is, you know, get a little index card or a scratch sheet of paper or whatever, and write out on one sheet of paper every single structure of the heart, all the valves, all the blood vessels, all the chambers, everything, and then mix them all up and then put them in order, right? And then mix them and then check it, make sure it's right, and then do it again, right? Just do that a few times and you'll get really good at the order of it. And again, the order is if you thought of a red blood cell entering the heart and then all the different structures that it would move through before it left the heart again, out the aorta, right? So that's the order. So the order of forward normal movement of the bloodstream, right? Get really comfortable at putting them in order, because then we're going to take it and we're going to work backwards from it again when we start talking about disease processes, when things are going wrong, like congestive heart failure. Cool. All right. So one thing that I'm big on is kind of study habits and tips and things that can actually help with learning, right? And I know a lot of you guys, so I know you're at various different places, but one of the really well documented things in terms of like focus and energy and clarity and everything is the fact that our brains can only take so much at a time, right? And you've probably seen that if you've been studying in the textbook and you're like, all right, I'm going to study for 4 hours, right? And then you realize that you've been flipping the pages of the textbook and you have no idea what those last couple pages said, right? That's because your brain can only just take and absorb so much. And so in study after study after study, it's around about 50 minutes before our brains can't really absorb a whole heck of a lot more, right? So we're right at the 50-minute mark, which is going to say our brains can't absorb a whole heck of a lot more than where we're at right now. So what I'll recommend is let's take a little 5-minute break, right? And we're going to do cardiac blood flow. We're going to talk about our coronary arteries. We're going to circle back and talk about some electrical conduction stuff. And we're going to do blood vessels, talk a little bit about the bloodstream, and really just round out that whole cardiovascular system, right? So I know that was a lot of all those structures, so I want to kind of give your brains a little break. So take the next 5 minutes, kind of close your eyes, decompress, do some jumping jacks, jump in the pool, whatever it is, refill your coffee, right? And then we'll jump right back on it. So a little 5 to 10 minute break, give your brains that rest that it needs, and then we're going to keep going. All right. Cool, cool, cool. All right. Coffee number 2. Okay. So yeah, as you guys are going, if you have any questions that come up, just pop it in the chat box, let me know. Otherwise, only a little bit of stuff left, and then we'll do just kind of open Q&A, which can be across any topic. It doesn't have to be limited to cardiovascular if you have other stuff that you have questions on. Otherwise, kind of talk about maybe some of the style of questions that you might run across. All right. Cool. Okay, so cardiac blood flow. We're back to this picture from the beginning. But again, it's back to that idea that the heart is tissue and the heart requires blood supply and oxygen and everything to stay alive. Right, so that's where we say we have the coronary arteries, right, that are carrying oxygenated blood to the heart tissue, and then the coronary veins that are taking the deoxygenated blood back from the heart back to the bloodstream, the systemic bloodstream, to actually be distributed back throughout the body. So if the coronary arteries are carrying oxygenated blood and the coronary veins are carrying deoxygenated blood, right, we can kind of think about now, based on the blood flow, and we said where it was when it was getting the oxygen and then where it was coming back to it, is we know the oxygen getting into the bloodstream was happening in the pulmonary capillaries, and then the pulmonary capillaries go back to pulmonary veins, back to the left atrium, to the left ventricle, and out the aorta, right? So that's the high oxygenated side. So somewhere in those structures, in those steps, has to be the branches that become these coronary arteries, because they have high oxygen levels, means it has to come from somewhere on that. So it has to come somewhere after the pulmonary capillaries, right? Because that's where the oxygen was. So somewhere after the pulmonary capillaries, through the aorta, all the way through those structures to the aorta, is where we have to have some branches that actually branch off of it. And so what happens is the heart has been developed to protect itself first at all costs, right? So the heart is going to feed itself first before it feeds the rest of the body, right? So it's going to send all that blood, all that oxygen out throughout the entire body, but it's going to prioritize itself first. Right? So as soon as the left ventricle pumps blood into the aorta, right? So as soon as that blood leaves the left ventricle and enters the aorta, there's immediately offshoots that become these coronary arteries. And there's another one that's back here behind this pulmonary artery. Okay. So as soon as the blood leaves the left ventricle and enters the aorta, as soon as it enters the aorta, there's immediately kind of 2 little highways that branch off. And one of them becomes the right coronary artery, and the other one is the left coronary artery, and then they branch down smaller from there, right? But immediately there's a right coronary artery and a left coronary artery. Right coronary artery going over to perfuse the right side of the heart, left coronary artery going over to perfuse the left side of the heart. And then again, that's where you get branches down where, one of the branches off of the main left coronary artery is the left anterior descending coronary artery. So on the left side, anterior is the front, descending is going down. So there's a big blood vessel going down the front of the left side of the heart. And it's the left anterior descending, or the LAD, right? And that's the one, or that's one of the branches off of there. We also have the circumflex artery that's wrapping around to the back. I got our right side. But again, just like we have the aorta, it branches and becomes the carotids, brachial arteries, femoral arteries, right? Everything kind of branches down. There's just more names as you branch out further and further. Right? So we have the right and the left coronary artery, and then they branch down further and further from there, until eventually they reach the capillary level, which is where that oxygen will leave the bloodstream and go into those cardiac cells to perfuse them, give them the oxygen, keep them alive, pick up the carbon dioxide waste product, right? And then on the other side of a capillary, we said were the veins. And so then those coronary veins take that deoxygenated blood and they actually dump right back into the right atrium. Okay. And just like we have the superior and inferior vena cava, bringing that deoxygenated blood back from the body, there's also a little inlet of the coronary veins that are dumping that deoxygenated blood from the heart back inside the heart. So it goes back into the heart, into the right atrium, so that it can go to the right ventricles, and the right ventricle can pump it to the lungs, and it can bring in a whole bunch more oxygen, right? And then back to the left side, out the aorta, and then some of that, again, branches off to perfuse the heart, right? So we have these coronary arteries that are bringing the oxygen to the actual cardiac muscle cells, and then the coronary veins that are taking that carbon dioxide blood back from the heart cells into the heart so they can keep circulating it forward. So cardiac blood flow, right? And again, that's where we can run 12 leads, right? And we can see the sign that somebody is having myocardial infarction on the anterior wall of the left ventricle, on the front of the left ventricle. Now, depending on exactly where we're seeing it on a 12 lead, gives us actually a little bit of a reasonable degree of accuracy to say that blockage is somewhere inside or somewhere on the front of the left ventricle. And the front of the left ventricle is perfused by the left anterior descending. So somewhere in that left anterior descending coronary artery system is where that blockage is actually built up. Right, so we can actually see and narrow down on a 12 lead exactly where on the heart that these this MI progression is actually happening. So that's how the heart perfuses itself, or how the body actually perfuses the heart, is again, it branches as soon as that blood leaves the left ventricle and goes into the aorta, it branches us off right at the base of the aorta. Some of that blood redirects back to the heart. The rest of it continues out the aorta, and that's where it branches to the lungs, or sorry, not to the lungs, to the arms, up the carotids, right? So we have those branches off the top of the aortic arch, right? Some of them go up to the head, they become our carotid arteries, that branch going up to our brain. Then we have the other ones that branch that are brachial arteries, right, going out to our arms, right, so the upper body ones. And then the aorta continues down. So we have the ascending aorta, ascending, the aortic arch, and then we have the descending aorta, which when we're talking about it in the chest, that descending aorta part is the thoracic aorta. And then it continues down, and that aorta continuing down to the stomach is the abdominal aorta. Right? So off of this descending aorta up here, that thoracic aorta component is little offshoots of blood vessels that go to perfuse the lungs, back to the question that was asked earlier. So just like the base of the aorta, there's the little branches that are blood vessels that go back to the heart. Right off the thoracic, the descending aorta is those branches of blood flow that go to actually perfuse the lung tissue, right? So not the blood through the pulmonary arteries and pulmonary veins, that's where the gas exchange is going to happen, but what blood vessels actually keep the lungs alive, right? Because the lungs need oxygen just like any other tissue needs oxygen. And so there's little bronchial arteries that branch off of the thoracic aorta, right? So again, kind of like we said, we've got big arteries that branch off smaller and smaller and smaller to go perfuse all the different structures throughout our entire body. Right? So that's where we're getting in on that side. All right. Go back to this picture that we've used lots of times. So the electrical conduction system. And so we really do, I mean, we talk about the heart in terms of the chambers and blood flow. We talk about the heart and the electrical system that actually is making those muscles contract. We talk about blood vessels, we talk about all these different stuff. So the electrical conduction system is a little bit easier to kind of strip away some of the layers to show where these things are at, right? But we know the heart, it's a muscle, and muscles are stimulated to contract based off of that electrical impulse, right? That electrical signal from the nervous system. Well, the heart has its own electrical system, this electrical conduction system. And one of the common terms that we use and we see, and you see on test questions and stuff like that, is the principle of automaticity. Right. Automaticity is that idea that any of these cells in the electrical conduction system can generate their own electrical impulse spontaneously. Right? Any cell can in this cardiac electrical conduction system. It can decide that, hey, I want to fire. Right? Now, thankfully, all of them don't just go chaotic for us unless something really bad is happening. Right? There's an organized system for it that when everything's going okay, the electricity flows very nice and organized throughout the heart. Okay. So it all starts up in the right atrium. Up in the right atrium, we have a little bundle of cells, okay? A little bundle of cells called the sinoatrial node, or the SA node, the SA node, sinoatrial node. And that's where it all starts for us, right? That's if you've heard, you know, depending on where you're at, the sinus rhythm, right? All of us healthy people, we're walking around, if you put us on the monitor, in a sinus rhythm, right? Sinus is referencing that it's starting, the electricity is starting from the sinoatrial node. Right? So that's where the electrical impulse starts, that then travels throughout the heart. Right? Now it can, right, because of the principle of automaticity, it could start somewhere else, right? You know, this cell down in the ventricles can get angry and irritated and decide that it wants to start firing, right? Thankfully, it doesn't normally, right? Something else has to be going on for that to happen, but it could, right? It could. But when everything's fine, it starts up in that sinoatrial node, that SA node, right? And that's why we say the SA node is the primary pacemaker for us, right? The pacemaker of the heart, the primary pacemaker, that spot that's firing first for us is the SA node. Right? It's driving that electrical impulse. Right? It has what we call a natural intrinsic rate. Right? Right? That if we just kind of neutralize everything, that little bundle of cells would like to fire, 60 to 100 times a minute. That's why the normal adult heart rate range is 60 to 100, because the SA node wants to fire 60 to 100 times a minute. Can it fire slower than that? Absolutely. Can it fire faster than that? Absolutely. Is it a problem? Maybe. It depends on the patient, right? So one thing we say a lot when we get into the cardiac treatment stuff in medical school is treat your patient, not the monitor, right? So if somebody has a heart rate of 50, we have to evaluate the patient and say, how are they handling 50? Are they sitting on the couch watching TV, not complaining of anything, and their heart rate is 50? They're fine. We're not going to do anything about it. If they're unresponsive on the ground and their heart rate is 50, that might be contributing to it. That might be a big problem, right? So we don't just jump at a number, we look at it in the context of how the patient is actually handling it. Now, the further outside of that 60 to 100 range that you go, the more likely it is to be causing problems, right? Like once you go less than 50, for most people, it's really starting to cause some problems. Once you go faster than 150, it really starts causing problems for people, right? But again, we're going to evaluate that in the context of the whole patient, the whole kind of clinical picture, the whole patient presentation that we have is we're going to evaluate that, right? But the natural rate is 60 to 100. That's why we're all walking around, and most of our heart rates are somewhere between 60 and 100. So that's the SA node. And so we said it starts the electricity, and then we have little kind of freeways, right? Little freeways of tissue, of electrical conduction tissue that help spread that electricity through the atria, right? And we have another little bundle of cells, just like we have a bundle of cells and we call it the SA node. We have a bundle of cells there kind of in the base of the right atrium. That's kind of where it's at, kind of visually in the overlap. And that is called the AV node, or the Atrioventricular node. Right? That's the AV node, AV. Between the atria and the ventricles, right, is the AV node. And so the AV node, its whole function is to just slow down that electricity that starts traveling through the heart. Because remember, when we start talking about the heart beating, the entire heart doesn't contract all at once. The atria contract, there's a slight pause, and the ventricles contract, right? And think about it, if you're listening to the heart, we hear two sounds, right? Bump, 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 right? So we actually have the atria contract, pause, ventricles contract. And that's to allow all of that blood flow to get kicked down from the atria down to the ventricles. So the ventricles wait, they receive all that blood, and then the ventricles contract to kick out all that blood. Right? It's also allowing for that time for those valves to snap shut. Remember, that's what we're hearing is the valves snapping shut. So the tricuspid and bicuspid valves, when those snap shut, that's the first sound that we hear. Right? And those are going to snap shut when the ventricles contract. Okay? Those are going to close so that the blood doesn't go from the ventricles back up to the atria. Right? So when the ventricles contract, tricuspid and bicuspid valves snap shut. That's the first sound. If it's bump, bump, right, the bump, the first one is those AV valves snapping shut. And if those snap shut, that means our pulmonic valve and the aortic valve are open. Right? So they close the access back up to the atria, and they open the access back to the pulmonary arteries and out to the aorta. So that's the first one that we hear. The second one we hear is now the aortic valve and the pulmonic valve snap shut, and those close, and the bicuspid and tricuspid valve opens up. Right? So the AV valves are open, and the semilunar valves are closed. And then when the semilunar valves are open, the AV valves are closed. Right? So they're always going opposite. So that's only working because there's a lag time, there's a delay, there's a holdup of that electricity that's allowing the contraction of the atria, and then the pause, and then that electricity goes down to the ventricles and it contracts the ventricle muscles. Okay? So that AV node there holds it up, and then it continues and it branches down the ventricles. Okay? And you have a little kind of offshoot electrical pathways that contract the ventricles. Okay? So it branches, right? That little electrical conduction tissue, right? Branches in this wall that separates the left ventricle from the right ventricle. Okay? That wall is the septum, right? Septum just splits the right side and the left side. Right? So we have two branches of electrical conduction system. It's where sometimes you'll hear people talk about they have a bundle branch block, and a finding that we find on the 12 lead, that there's an issue in these bundle branches, which are the split of the electrical conduction tissue traveling down the septum before it works its way back up the ventricles. Yeah. So that's what it is. If I can just change colors here. So we have, again, that atria, or that SA node fires, or we call it depolarizes, right? And that electricity travels through the atria, and then it gets held up in that AV node, split second, allowing for the atrial contraction to happen. And then it sends that electricity very fast down the ventricles, and then works its way back up, now causing the ventricles to contract. Right? So it works its way through atria contract, pause, ventricles contract. Or electrically, we use the terms atrial depolarization. So electrically it's firing, it depolarizes, which should stimulate the atria to contract. And then that electricity continues down to the ventricles, causes ventricular depolarization, or ventricularly it fires, which should stimulate the ventricular muscles to contract. Right? So again, the mechanical process of the contraction is not the best proper terminology. We should use depolarizes, that electrically it fires. And that should entail, or it should trigger those muscles to actually contract. So that's kind of the basis of it. We have the SA node, again, as the primary pacemaker, right? Has a natural intrinsic firing rate of 60 to 100 times a minute. And then we have the AV node that holds that electricity, and then it shoots down through the ventricles. Right? So that's the whole kind of flow of it. And that happens every single time our heart beats. Right? If you're palpating a heartbeat, like it's electrically it fires, recharges, fires, recharges, fires, recharges. Right? It's just this constant electrical firing, and then the electrical recharge. And then it fires again, it recharges. Or it depolarizes, fires, and repolarizes, recharges. So depolarizing is firing, repolarizing is recharging. Fires, recharges, depolarizes, repolarizes. And those are the terms that we use for it. Now for us, right, when we think about electricity, we think about, outlets in the wall and batteries and things like that. So we have to figure out, like, where's this electricity actually happening for us? Right? How are we getting electricity inside the heart? Yeah. So electricity inside the body is all because we have electrolytes. Right? It's the electrolytes in our body. Right? They have little positive and negative charges, electrical charges. And so it's actually just the movement of these electrolytes in and out of cells that becomes the electrical depolarization, or the firing, which stimulates the muscle contraction. And then the electrical repolarization, or recharging, is just some of those electrolytes moving back. Okay? So it's this electrolytes just moving back and forth, back and forth, back and forth. Okay? And so that's some of the ones, when we look at electrolytes, right? Na is sodium, right? Sodium, and there's a little positive. Right? So because sodium has a little positive electrical charge. Right? Calcium, little positive electrical charges. Potassium is K. It's a K. Right? Positive electrical charges. Chloride, little negative electrical charge. Right? So it's these electrolytes moving in and out of the cardiac cells, in and out of each of those cardiac muscle cells, these electrical conduction cells, is these electrolytes. They move into the cell, they move out of the cell, move into the cell, move out of the cell. Positive electrical charges move and move and move and move. And it just keeps shifting that electrical concentration, right? Or the electrical gradient that it creates between the two, right? It just creates an electrical charge just because there's enough of these electrolytes on one side compared to the other side of that cell membrane. Right, so it's just electrolytes moving back and forth, back and forth. Now, a couple of them are more impactful on cardiac functioning than the others. And the ones that will impact cardiac functioning a little bit more is calcium and potassium. And always remember, if we're talking about looking at the electrical conduction system or putting somebody on the monitor and actually looking electrically at what their heart's doing, right? We look at ECG, right? It's English, ECG, or EKG originally in German, I think. Right? Electrocardiogram with a C or electrocardiogram with a K, ECG or EKG. Just remember that ECG, calcium. EKG, potassium. That's how I always remembered which two electrolytes are going to kind of disproportionately impact the cardiac system, right? Whereas sodium with N is going to go and impact our nervous system a little bit more, right? Neurological emergencies. And sodium imbalances will result in a lot of like, muscle cramps all the way up to seizures, right? So will sodium impact the heart? Sure. Will calcium and potassium impact the brain? Sure. Right? But calcium and potassium, if those are imbalanced, they're going to really hit the heart first, right? We're going to have more issues with the electrical conduction system in the heart. If sodium is imbalanced, we're going to have issues in the brain probably faster than other places, right? So calcium and potassium are big ones on this cardiac electrical conduction system. And again, the other day, I was like, hey, ECG and EKG, right? C for calcium, K is potassium, right? Those two, right? If potassium's high, it'll kill you, right? It's a big one, right? So those will really mess up the electrical conduction system and are much more likely to push us out of a sinus rhythm into a different rhythm like ventricular tachycardia or ventricular fibrillation, or push us into some of those lethal arrhythmias that'll actually kill us or put us into cardiac arrest. So these electrolytes, and again, it's a whole other day, we can really spend time just talking about those electrolytes moving in and out and what that looks like. But right now, we're just going to kind of keep it at the level of just understanding that, hey, electricity in the heart is purely just the movement of electrolytes. Right? And two that are a little bit more impactful on cardiac functioning is calcium and potassium, and making sure that those are proper levels inside the body. All right, so here it is again. I'll take a quick second and draw my structures back in as we go. There's my SA node up here in the right atrium. And so this is what a normal good sinus looking complex is. We'll kind of review back through all of it. And so we have the P wave. We have our P wave as the little bump. We have our QRS complex is the big spike. And then we have the T wave afterwards. And so it's alphabetical P, QRS, and T. Now we're going to ignore the segments and the intervals and all those other things for now. We'll do a ECG day or multiple days later. I have a P wave, QRS complex, and T wave. Okay. And so what happens is when the SA node fires or depolarizes, right, that's right here. Right. SA node fires, it's the start of that little P wave, right? It's the start of that little bump beforehand. And then that electricity, I said, starts traveling through the atria, right? Electrically, it travels through the atria. And as that electricity is traveling through the atria, right, it generates that little bump, right? And when we actually put somebody on the monitor and put those stickers on the monitor, Right? All we're doing is just watching the movement of electricity. Right? Right? Some of them are negative electrodes, some of them are positive electrodes, and all we're doing is looking at which way is electricity moving. So the only way you get squiggly lines to show up on the monitor is if that electricity is moving through the heart. Right? So as that electricity moves through the heart, moves through the atria specifically, it generates that little bump, right, that we call the P wave. Right? The little bump that we call the P wave. Change colors again. Then we said that electricity gets held up in the AV node, right? And gets held there. And so if electricity is not moving, we said the only way we get squiggly lines to show up is if that electricity is moving. So it holds up that electricity in the AV node. That's this little flatline part right there after the bump. Right? That little flatline part. So it just holds the electricity. And then very quickly, it's going to send, choose a different color, orange. All right. Then it sends that electricity down the ventricles, right, which is the big spike, is when it goes down the ventricles. Right? And then as it works its way back up the ventricles, do purple. It works its way back up the ventricles. That is the other side of this big spike, going back down. Okay. So that's kind of, I mean, the directions there, if you can see it. I apologize if not, I'll try to do a better one next time with a bigger pen. But that's what it is the electricity starts in the SA node. It travels through the atria, right? Or what we call atrial depolarization. Atrial depolarization, which is the P wave. Right? P wave is atrial depolarization. Is atria fire, right? Electrically they fire, they depolarize, and that should trigger the muscles of the atria to contract. And then we had electricity held up there in the AV node. And then it sends it really fast down to the ventricles, right? Travels down and then back up the ventricles. And we call that ventricular depolarization. And that's that QRS complex, which is actually the Q wave. The R wave is the big up spike of the spike. And then the S wave is the down spike of the spike. So it's a QRS complex. And we don't isolate them separately too often. Most of the time we talk about just the entire QRS complex. And that's the ventricles firing or electrically depolarizing, if we're using the right terminology. It's ventricular depolarization, which should trigger those ventricular muscles to then contract. Right? So electrically it fires, stimulates the atria to contract. Pause, then electrically it fires, stimulates the ventricles to contract. Right? And then the T wave over here, that slightly bigger bump after the big spike, the T wave is the ventricles recharging or repolarization. So ventricular repolarization. And so we see that electrical shift as those ventricles, just because they're much, much larger than the atria, is we see those ventricles recharging or repolarizing. Because we said once it fires, it immediately has to start recharging so that it can fire again, because our heart needs to fire, 70 times a minute, whatever our resting heart rate is. So it depolarizes, repolarizes, depolarizes, repolarizes. Electrolytes move the other way. Electrolytes move the other way. That's how we get that to happen. So the T wave is technically ventricular repolarization. So if we have the atria depolarized, then the ventricles depolarize, and then the ventricles repolarize, inevitably people will ask, well, when do the atria repolarize? I'm not seeing them on here. And the reality is just because they're a lot smaller than the ventricles. Okay? That big QRS complex of ventricular depolarization only resulted in the T wave repolarizing like that. So we look at the P wave of the atria depolarizing, atrial repolarization is going to be very, very low, right? To the point that we might not be able to see it, or it might actually be happening during the ventricles depolarizing, right? When they're depolarizing, the atria are already starting the repolarizing process. Right? So a lot of times the electrical signal of that QRS complex when the ventricles are firing is a really big electrical signal. That's why it's that big spike. It's kind of hiding the little electrical signal of those atria recharging or repolarizing. So the big three components that we see of the P wave, the QRS complex, and the T wave is the atria depolarizing, the ventricles depolarizing, and then the ventricles repolarizing or recharging. Cool. Yeah, so question a minute ago. So what you're saying is that potassium and calcium make the heart contract, basically? Absolutely. Right? They're big on that depolarization. Right? Again, because electrically what they're doing is helping with that depolarization, which is the electrical firing. And when that electricity fires, it stimulates that muscle to contract, the heart to contract. Yeah, so it's very kind of simplified is the electrical firing that's happening. And then those calcium and potassium ones move back the other way when it's recharging, so that then they can help it charge again. Yeah, absolutely. Good. All right, so that's the electricity moving through. Like I said, we can do, and we'll do just whole segments just on the electrical system and really diving into these electrolytes a lot more, and also rhythm identification. And we do some of these sessions on rhythm identification too, just to understand how things actually start kind of manifesting differently. Okay. All right. So, like I said, this whole one, we've been spending all of our time talking about the heart, right? But I said the whole thing is really the cardiovascular system, right? And the cardiovascular system is the pump, the pipes, and the fluid, right? Or the heart, the blood vessels, and the blood, right? So that's the cardiovascular system. Cardiovascular, vascular, the vessels, the blood vessels. Right, so we're going to talk about all three, these two just briefly, right? But that's where we also run into shock. Right? Shock is a breakdown of one or more of the pump, pipes, or fluid. Right? If you don't have enough fluid in the system, it's hypovolemic shock. If your heart's not working properly, it's cardiogenic shock. If your blood vessels are too big, too dilated, right, it's a distributive shock, like anaphylactic shock or neurogenic shock. Right, so all shocks are a breakdown or an issue of at least one of the three, sometimes more, but at least one of the three. Okay. So talk about the heart, we talk about the blood vessels. Okay. And this is where we can go back to it and see the inner layer of the blood vessel. Right? We said there's 3 layers. It looks like more, but it's still technically 3 layers. Right? And blood vessels, they use this tunica word. So tunica intima, inside, that's the inner layer. And then we have this big middle layer. And you see especially this section that they're trying to there, kind of looks like muscle cells, is what they're trying to say, because we said the middle layer is always the big muscular layer. Right? So that middle layer is the tunica media. And then the outermost layer is the tunica adventitia. So intima, media, and adventitia, inner, middle, and outer. Right? And again, the middle layer, right? The middle layer is the big muscle mass, right? Right? It's the big muscle mass, right? When we talk about vasoconstriction and our blood vessels clamp down or in shock, we shunt blood to the core. Well, the shunting is those blood vessels all becoming really tiny little pipes, right? They vasoconstrict and clamp down. That's the muscles actually contracting and clamping down, making that a smaller pipe. And if you put a smaller pipe, right, you're restricting the amount of blood flow that can actually pass through that blood vessel, right? So the middle layer is what's doing the muscle contraction for vasoconstriction or the muscle relaxation for vasodilation, right? It's all those blood vessel muscles contracting and relaxing. We just call it vasoconstriction and vasodilation. Okay? But again, there's always that kind of inner and outer protective layer, and then the middle layer that's doing all the work, right? Doing all the work. So tunica intima, tunica media, and adventitia. And then again, remember on the artery side, right? Arteries are high pressure, and veins are low pressure, right? And arteries are away from the heart, and veins are back towards the heart, right? It's like the pulmonary artery was the blood flow leaving the heart, pulmonary veins bringing blood back to the heart, right? The aorta, the biggest artery in the body, going away from the heart, taking blood to the body, and then the big vena cava, veins bringing the blood back to the heart. So arteries are away from the heart, veins are back towards the heart. Arteries are high pressure, veins are low pressure. Most of the arteries are high oxygenated blood, and veins are deoxygenated blood, except it's backwards, remember, with the pulmonary arteries. Pulmonary arteries sending that blood to the lungs is deoxygenated, and the pulmonary veins are bringing that high oxygenated blood back to the heart. So vast majority of our arteries are high oxygen blood, except for pulmonary arteries. And fetal circulation, which is another day. Okay. So blood vessel walls is really it on this one for kind of what we're going to talk about. And then on the bloodstream, we have 4 components. We have the fluid and the stuff floating around. Okay. So the fluid is the plasma, okay, and the stuff floating around, they call the formed elements. Formed elements. And the big 3 things we have are red blood cells floating around. Fancy word for red blood cells is, can't spell in the mornings, is erythrocytes. Cytes are cells. Erythro is red. So erythrocytes are red cells. Those are red blood cells. Other thing floating around is we have white blood cells. White blood cells are also called leukocytes. Cytes are cells. Leuko are white. So white cells are white blood cells. And then the third thing floating around of these formed elements are platelets that help with clotting. Platelets. So red blood cells, white blood cells, and platelets are the things that are floating around inside our bloodstream. That's all the stuff floating around in the bloodstream, which again gets the name deformed elements. It sounds cool, right? Deformed elements. Red blood cells, white blood cells, and platelets. So the fluid, again, is plasma. And there's always slight ranges, right? It's about 55% of total blood volume is the plasma, and 45% of the blood volume is the red blood cells, white blood cells, and platelets. And in terms of kind of size and quantity and everything, the bulk majority of that is our red blood cells in terms of the real contents. Platelets, there's a lot of platelets, but they're super, super tiny comparatively. Right. So red blood cells, white blood cells, and platelets is like about 45% of your total blood volume. The fluid, the plasma, is about 55%. So it's about a 55-45 split. Cool. So I think that's it. Pump, pipes, and fluid timed up perfectly. Right. Thank you for joining in on this. I know a lot of you guys held in the entire kind of 2-hour section. For the last little bit, I wanted to leave a little bit of time just for either questions about cardiac stuff, right? Ideally, just because we're kind of fresh and focused on that. But if there's other stuff, we got about 15 minutes that if there's other stuff that you want to have questions about, let me know. Otherwise, I forget, I was going to put it on here. Change my color here. Otherwise, and stay tuned for more sessions. Okay? I'm going to do Tuesday mornings. I'm in Arizona, so this is all Pacific time. I know some of you guys are from out of state. Tuesday mornings at 8 a.m. To 9 a.m. So do 1 hour Tuesday mornings. Will be a certain topic. And then Tuesday nights, 8 p.m. to 10 p.m. We'll do another session. Okay. The 8 a.m. to 9 a.m. it'll be slightly more BLS focused. Okay. And then 8 to 10 that night is going to be a little bit more ALS focused, where we might do things like capnography and 12 leads and rhythm identification, and join any of them, especially my medic students. Right? It's always BLS before ALS. So don't kind of overlook. If you've got the time, I encourage you to get on all of them. Right? So Tuesday morning, Tuesday nights, and then Saturday mornings. Right? Like today, I'm going to keep doing these moving forward. Is a little bit both. Right? So again, a little bit kind of BLS, and we're going to start pushing some of these sessions a little bit more ALS. And I might try to slide in another ones at Fridays at noon. You know, that one's a little bit more variable, but at least these Tuesdays and Saturdays, and, you know, depending on the interest and the number of people that can actually join these sessions, I might start flexing those around or trying out some other ones as well. So if you have any questions on these times or whatever, but I'll keep sending you guys emails just like you guys got from me this week about them. So I'll send them to you, and I'll send you the Zoom links and everything that can go through it. I'm trying to funnel my kind of educational communications, right? I know everybody's got my work email address, but that gets bogged down with everything. So I have my personal email address here, that if there's more kind of education focused questions, or if you want, you know, quick little videos, or if you have things that are more pressing because you got an exam coming up that you want help with, shoot me an email there. You're much more likely to get a educational response as opposed to a programmatic question or something else getting lost somewhere else. All right, what we got? Cool. Thank you. Awesome, you're welcome, guys. I appreciate that. So if we miss, where can we find the recordings? So for those of us that were using GoToMeeting for some of our prior stuff, we finally figured that out, was getting those links out to you guys. But these I'm going to be downloading and just figuring out a different storage kind of database for them so that everybody can just access them. So stand by. I'll shoot you guys a message and let you know when and where these videos are. So when they get published and where they'll actually be able to find them. For at least starters, I'll probably just try to quick flip them up onto YouTube, and then I could just send you the YouTube links for them. In the future, they might all be housed into a website that you guys can just access that site and have all of them go back as far as you want. Anthony, if you didn't get an email from me or anything, shoot me an email here, and then I'll make sure that you get it. And they will be different links. So I know, some of you guys were reaching out. You needed the meeting code or the password or anything like that. So that was just a kind of trial and error thing on my part. I didn't realize that you needed it. So I'll make sure that when I send you guys the link that you get the full meeting password and everything like that. So there shouldn't be any issues for the people that were having a hard time joining at 8 o'clock. So it will be a new link for each session. And those will just keep coming out probably a week or two at a time. Right? I'm going to pick some topics and just start mapping out what the dates and what the topics are going to be on. So you guys shoot me some messages or whatever if you have particular topics that you really want. So yeah, just like this question for blood physiology. Absolutely. Absolutely. I'm definitely trying to start right now with the big bang for your buck topics that I think are just universally asked about in EMT school and paramedic school and national registry and everything. So I wanted to start there, but we'll keep pushing forward. So we can definitely do a whole day on blood beyond just the little breakdown that we did here. Cool. Yeah, you're welcome, Ben. Thanks for joining. Cool. All right. Absolutely, Mark. Thank you. So I said, I'll leave it up here for a bit if you guys have any other questions. See you, Rich. Thanks, man. Later, Anthony. See you, Ben. Thanks. All right, Mark, what we got? Just going back to the aorta, how does the blood go back into circulation? All right, get back up here. Where's the best one? All right. Let me check the color. See you, Charles. Nairobi, thank you. Thank you. All right, Mark, so if we took the heart here and kind of split it back into our structures, I had right atrium, right ventricle, left atrium, and left ventricle. But that left ventricle contracts and it sends that blood out the aorta, and that blood goes just everywhere throughout the body, right, and continues down to the lower body. Right, so that blood gets sent out to the entire body, and those big arteries just branch down smaller and smaller and smaller and smaller and smaller little blood vessels until they branch down to the capillary levels at every single cell throughout our whole body so that we can deliver the oxygen and pick up the carbon dioxide. And then those capillaries turn into veins, and those veins go from really tiny little veins up to bigger and bigger and bigger veins, and bigger and bigger and bigger veins. Right? And those big veins eventually branch back into that superior and inferior vena cava that then dumps the blood into the right atrium. Right? So it's out the aorta, out to the entire body, branches of smaller little arteries to the capillaries throughout our entire body where gas exchange happens, and then back onto the venous side, back into it. From the heart. I got you. I'm sorry. All right, so let me erase some of these lines. Perfect. All right, so this is a good visual because they color code some of this stuff. So we have right off the base of the aorta is where we have, the big coronary arteries, right? These red ones, the coronary arteries. And those branch down smaller and smaller and smaller down to capillaries. And then the capillaries on the other side, they become veins. Right? And then we have these coronary veins, the blue ones. And those coronary veins all eventually dump the blood back into the right atrium. Right, so branching off the aorta is where it goes to send that high oxygen arterial blood to the heart. And then the coronary veins, right, bring it all back and dump it back into the right atrium. So that that deoxygenated blood can go back to the right atrium, to the right ventricle, and then right ventricle to get pumped out to go back to the lungs to get oxygenated again. So we have the coronary arteries, branch down smaller to the capillary level, and then they become coronary veins on the other side that dump right back into the right atrium. Cool, good. Yeah, the coronary veins we just don't talk about much, honestly, right? We don't talk about the coronary blood flow too much other than just the heart attack side of it where we get a blockage building up in one of those coronary arteries. So it's really the only time that we really talk about it in kind of the starting education stuff, but then you know, we talk about it even less than with the veins. So straight to the right atrium, or do they go to the right vena cava into the atrium? It really all just kind of comes together, right? That right atrium is almost kind of like just a ballooned out portion of the vena cava. So it all just dumps kind of right back in together. Cool. Good questions. Appreciate everybody's kind of feedback in here. Well, Valerie, yeah. So yeah, you saw how they posted on Facebook. Go back, shoot me an email, right? Shoot me an email. That'll probably be the fastest way right now, but I'll be able to send you something on Facebook as well to make sure you get the emails with it. So I'll post them there, but I'll get you emails as well. Yeah, if you shoot me an email, I'll do it. Otherwise, just keep an eye out on Facebook, and I'll get something posted up there for you to kind of sign up for the emails. Cool. You're welcome. Thank you. I'm glad. See you, Vince. All right, Mark, let's see. Last question. When it comes to the pump, I try to think of a balloon. When it inflates, it pushes blood down. When deflated, it fills up the atria. Is that a way to think about it? So, let me think about that. So most of the balloon analogies that I use or have had people use is more on the lung expansion side, because they're more like balloons where they fill up with air and then decompress. But let me think about this with the heart. So when it inflates, deflates, fills up the atrium. Let's see, how can we think about that? So if you've got a balloon analogy kind of working in your mind, you erase a little bit of this. See how I would do this. All right, so balloons. Cool, so positive and negative pressure. Honestly, that's probably just because of how much we'll use balloon analogies with the lungs and positive and negative pressure driving the lungs. Kind of my first kind of gut reaction is be careful with that, because I think that's going to cause a lot of confusion then when we add the respiratory stuff in and we talk about that actually being a negative pressure system and a positive pressure system. So it might actually start to cause more confusion when we add more stuff into your knowledge and stuff with anatomy and physiology. So my gut reaction is be careful just because of how much that's used on the respiratory side. But if we were thinking about it with the heart, right? The atria receive blood, so they fill up, so the balloons will get bigger, and then they contract, right? Because the ventricles don't have the blood, right? Don't have much blood when the atria has a lot of blood. So atria are full of blood, ventricles are waiting for that blood. And then the ventricles open up more as that blood flow fills them up, right? So it's not that they create a vacuum like a negative pressure, right? It's actually the movement of the blood and the contraction of the atria pushes that blood into the ventricle. So again, it's, gosh, yeah, it starts to cause some confusion. It wouldn't be a negative pressure sucking it in. It's more of a positive pressure because the atria actually contract to push that blood down. That's why they fill up. So atria contract, squeeze down, and squeeze that blood into the ventricles that then fill up. And the ventricles contract, send that blood out to the body. And when they're sending the blood out to the body, the atria start filling up, right? So those send the blood to the body, atria start filling up because they're receiving the blood from the body. Right, so it would, I mean, it does kind of become a back and forth thing like that. But again, it's all really kind of contraction driven. So it's a lot more positive pressure driven than like a positive negative pressure balloon type thing. But I mean, it would work that way. The atria receive the blood and they fill up, and the ventricles don't have much blood, right? And then the atria contract that blood down to the ventricles. So the ventricles fill up because they receive that blood, and the atria just contract it down. And then the ventricles pump that blood out the aorta at the same time that the atria start filling back up because they're receiving that blood from the body. And they're filling up not because it's a vacuum, but because we have just the pressure of the bloodstream moving everything through. And so it's still the pressure of the blood coming back to the atria that are filling them back up. And it's the atria contracting, pushing that positive pressure, that blood into the ventricles. So it's really all positive pressure. The true negative pressure vacuum thing is what we actually create that pulls the air into our lungs, which is why a lot of people will use a more of a balloon analogy for the lungs as opposed to kind of cardiac blood flow. I'm not sure, does that help a little bit? Cool. Cool. Okay. Cool. Absolutely. You too, Mark. Thanks. Okay. All right. Kind of kept it pretty spot on with the 2 hours. So I'm going to work on getting this video processed and uploaded somewhere for you guys to see it. If you want to go back and watch it later. Again, if you had other questions or whatever, shoot me an email. I really appreciate it. I know my wife always jokes with me that I get long-winded when I start teaching. So I really get a lot of just internal happiness and satisfaction when I keep it to the window of time that I've committed to without feeling rushed or shortchanged or whatever. So I think this 2 hour block for the cardiovascular stuff was good. And the reality is we could have probably spent 12 hours just talking about cardiovascular stuff. So again, these sessions, I'm going to try to keep them super focused. Right? Because inevitably everybody gets lost. They get down into the weeds, like super deep down anatomy and physiology, and they lose all grasp of kind of the big picture of it. And in entry-level training, which I've really identified as kind of my area, entry-level EMT training, entry-level paramedic training, right? Keeping it focused and keeping it at a certain level of depth is the best place to be right now. Once you're great, once you're certified, you're curious and want to push further, please push further. Like anatomy and physiology is fascinating. But we have to keep it kind of focused at a level that is going to be realistic for what you guys are getting in class and realistic for what you guys are going to see on national registry. So that's the kind of fine line that I try to walk is, you know, giving you a better understanding, giving you something more in depth, but keeping it focused to a level that you're going to see on, exams and national registry and everything. So I hope it was helpful. And thank you guys for participating. We had a good group in here today and the questions were awesome. So I'm going to sign off here and I will see you guys hopefully Tuesday. If not, another day or somewhere, right? So have a great weekend, you too, Valeria. Thank you very much. And I will see you guys later. Bye.